may stuck with their work and cannot join, so that it will
Yes.
benefit the big group. Thank you very much.
Yeah.
Okay. Um, we have quite a number of the attendee already, and we can start. We got the CV from you. Um, thank you very much. Hi, everyone. Good morning. This is the first lecture of the year for BMS by OSU Expert. Today is great opportunity for us to have Miss Jessica Wright, who is a clinical instructor under the Division of General Internal Medicine and Geriatric at OHSU. I have seen her qualification is quite long. So maybe Jessica, you can fill in for me properly. Okay. I pass the baton to you for the fall prevention lecture today. Thank you.
Perfect. Thank you so much. And thank you for having me. Before I share my slides, can people just put in the chat maybe what area of medicine they work in, if they are students, if they are already clinicians, if they are physical therapists, and just put it in the chat. I'm also, before I get started, because I will forget, we have 2 hours allotted for this lecture. I am probably not going to talk at you for 2 solid hours, so we'll have plenty of time for questions. I am on a small laptop, so it'll be easier for me if you put your questions in the chat along the way, and then I can answer them at the end. And then we'll also have an opportunity for everybody to ask questions at the end to have a good discussion about fall prevention and maybe compare notes about how fall prevention is done where you live. So without further ado, I'm going to share my screen. And can I get a thumbs up from someone or a unmute yes that you can see my screen? Perfect. I see a thumbs up. Awesome. Thank you. So let me kind of get in presenter mode so that you can see it even better. So from the very beginning, this is Multnomah Falls. This is a very famous falls where I live in Portland, Oregon. And it's just such a beautiful picture. And I thought, how can we talk about falls without also including a famous waterfall here? So as was mentioned earlier, I'm a clinical instructor at OHSU. I am a physician assistant, which I don't know that profession exactly exists where you guys are, but it's similar to a nurse practitioner. We have kind of an abbreviated, quick-paced medical education, and similar to physicians, we are allowed to diagnose, treat, and prescribe medications. So I wanted to include that just in case you weren't familiar with my profession. And how, you don't have physician assistants in Thailand, yes. And how I came to speak with you about this topic and a little bit about my clinical background. So my practice in the specialty of older adults, I have worked in the hospital setting. I worked at a skilled nursing facility as a medical provider, so a rehab facility. And I have also, part of my training has been doing home visits with fragile older adults. So really have been in a unique position to be able to see older adults across the spectrum of the medical setting. Oh, good. So our objectives today are we're going to talk a little bit about some fall facts, including prevalence and mortality. We're going to identify risk factors that contribute to falls, talk about some screening tools that we can use to determine what someone's risk for fall is. We're going to discuss some interventions to prevent falls and hopefully, once a fall has occurred, prevent future falls. And then we're going to, at the very end, discuss some upcoming falls research and technology that I thought was interesting to be able to share with you guys. So I thought it would be important for us to first get on the same page about what a fall exactly is. And this is a definition that's offered to us by the World Health Organization. They did a global report on fall prevention in older adults. And they define falls as inadvertently coming to rest on the ground, floor, or other lower level. And I thought that was, we think about falls all the time. I don't think very often about how to define a fall. And so I thought it was a great starting point for us to get on the same page. Also from the World Health Organization are some national statistics or global statistics, that I'm going to present today. And that's that approximately 28 to 35% of people 65 and over fall each year. And that as people get older, that rate goes up with people 70 and over falling at a rate of over 32 to 42% per year. And that, as you can imagine, frequency of falls increases with age, but also with frailty. So even in a younger population, if they are more frail, they're at increased risk for falls. And approximately 30 to 50% of older adults in long-term care fall each year, with about 40% of those individuals having recurrent falls. Falls end up resulting in some significant injuries. About 20 to 30% of mild to severe injuries are related to falls, and they account for 10 to 15% of all emergency room visits. More than 50% of injury-related hospitalizations are for patients 65 and older. And common injuries related to falls and that end up in fall-related admissions include hip fractures, traumatic brain injuries, and upper extremity injuries. And an important thing to know is that when an older adult ends up in the hospital with a hip fracture, they often have a longer length of stay. And certainly what we see with our geriatrics team, the longer an older adult is in a hospital, the more they're at risk for adverse events like delirium or a functional decline related to their decreased mobility. And that older adults, when they experience a hip fracture, whether they are hospitalized or not, are at an increased risk of mortality, with about 20% dying within 1 year of injury. And that increased mortality is present whether they have their hip fracture repaired or not, which I was surprised when I learned that even if it's surgically repaired, they are still at very high risk for mortality. Falls also cost a lot of money. And while the World Health Organization did an excellent job talking about this, there's a lot of variation between countries, but overall, when an injury occurs related to a fall, and there's a hospital stay, that accounts for about 50% of the cost. So that's kind of telling us stuff that we already know, that hospitalizations can be pretty expensive. There's a wide variability between the cost for long-term care globally, ranging anywhere from 9.4 to 41% of the total cost for the fall. And in the US, it's expected that falls are going to cost approximately $240 billion annually by 2040. And then the other thing that wasn't mentioned in the literature, but I think is important to point out, is that falls also have a financial impact for caregivers who have to take time off work to either attend to their loved ones in the hospital or even provide care for their loved ones at home. And so there's a significant financial risk related to falls in that area as well. The other thing that's important to note is that falls end up leading to increased dependence, decreased mobility, depression, confusion, and a fear of falling. And all of that goes together to what is called a post-fall syndrome, that constellation of medical conditions or symptoms. And the other important thing to note is that falls are a leading cause of falls. And so if someone has already had a fall, that puts them at significantly more risk for a future fall. And so really prevention is key. If we can stop any older adult from falling, we're really preventing increased mortality and morbidity. There's also a significant risk for falls, for fatality related to falls. Falls account for about 40% of injury-related deaths, which is a significant amount. And that these fatality rates increase exponentially with age, and certainly with the highest population being at risk are 85 and older. And I think this kind of goes into the older adults are among the fastest growing subset of the population, and that people age 60 and over by the year 2050 are expected to reach over 2 billion, and for the first time ever are expected to outnumber children 14 and under. And of that growing population, 80 plus year olds are expected to be about 20% of that future population. And so what that tells me that as time goes along, we can expect that as the older adult population increases, falls and falls related hospitalizations as well as complications will also increase. And so ultimately, the more we are able to position ourselves to be experts at fall prevention and fall screening, the better off we'll be. And hopefully we can help kind of curb some of those numbers that we anticipate may occur. We're going to do a little bit of audience participation. I'm going to take myself out of presenter mode for a minute so I can see. And I'm going to have people put in the chat or even unmute themselves and say out loud, just kind of off the top of their head, why do they think older adults fall? And I offered to put it in the chat, and then I can't access the chat presenter mode, so that's not very helpful. How about you unmute yourselves and offer up some reasons why older adults fall? Loss of balance, okay. Muscle weakness, excellent. Luckily the chats are floating on my screen. Visual impairments, yes. Perfect. Have you guys had this lecture before? You're absolutely right. So I'm going back into presenter mode, and we'll talk about the reasons for patients falling. This too is from the World Health Organization, and they talk about this constellation of risk factors that all really feed into one another to cause falls. And certainly any risk factor in and of itself can increase our risk for falls, but as those risk factors increase, so does the risk. So we're going to talk about each category individually. Biological risk factors. So I'm going to put in the chat already, age, gender. This was surprising to me, but women are at higher risk for falls than men as they get older. Sarcopenia, which is that muscle loss. After the age of 50, we start to lose about 2% of muscle mass a year if we're not exercising. And then after the age of 70, we lose about 3% of muscle mass annually. There's also some age-related changes to balance. So our primary sensory system that we use for balance starts to lose sensitivity, and that's normal with aging. And the example of that is like our proprioception or our vision, we rely on those things to help us keep upright. And those lose their sensitivity as we get older. And then our premotor cortex has to work harder with these tasks while we have fewer neurotransmitters and cell bodies because our neurons are aging as well. So it really becomes this kind of, unfortunately, this kind of feedback loop or this cycle. And then, of course, medical comorbidities, which we'll speak a little bit about later. Behavioral risk factors. So the one we see a lot in the hospital is polypharmacy, essentially that's defined as being on more than 4 medications at a time. It's defined as being on medications that are no longer indicated, as well as medications that start to interact with one another, or when you're using a medication to treat a side effect of the other medication that you're prescribing. Alcohol use is a big contributor to falls. And then, as kind of mentioned before, with the muscle loss, sedentary behavior, and then not adhering to mobility recommendations. We see this a lot as well, that someone has said, well, I was told to use a walker, but it's just so clunky, and so I don't use it. And that obviously ends up being a risk for falls. Environmental risk factors. So there are the regular ones that we think of in the home. If someone has narrow stairs or loose loose rugs, slippery surfaces, or insufficient lighting. But there's also environmental risk factors outside of the home, like cracked or uneven sidewalks or high curbs. A lot of our buildings, especially the older ones, are not really designed with older adults in mind. Maybe there's a lot of stairs to get from one level to another, and there isn't handrails. And then poor lighting in public places can be a risk factor for falls as well. Some socioeconomic risk factors. So they actually have found that older adults who are at the lower income level or have lower education are at increased risk for falls. An additional socioeconomic risk factor is if they have inadequate housing or if they have social isolation. And we talked a little bit about depression being kind of a risk factor for falls. If they have limited access to healthcare or limited access to social support, they're at higher risk for falls. And then if there's a lack of community resources in the community that they live in, that increases their risk as well. But there are some protective factors. So along those kind of behavioral risk factors, if someone stops smoking, maintains a normal weight, or gets regular exercise, these things help reduce their risk of falls. Also, if they do some of those modifications to the home to decrease the environmental risks, such as installation of grab bars, putting railings in the home, if they get rid of those throw rugs, or loose rugs is another way of thinking them, and if they put in slip-resistant flooring. And then if we think about age-friendly design in our new construction, and I put that in there because as we as clinicians are involved in our communities, we may be involved in kind of housing projects or even community development projects. It is on us to also bring forward the needs of older adults as people are thinking about building these buildings. And so that's a little bit of a plug from me for all of us to have them consider older adults in their construction. We're going to do a little bit of audience participation again. These are actually photos from people's homes, and I'll just have people kind of put out in the chat or unmute themselves and kind of just fire off what kind of hazards they see in these photos. I can tell you the big one that I see, and I would see it a lot when I was doing home visits, is the one on the left. No one is going to be able to get any sort of mobility device in between that bed to get, to safely be able to ambulate from the bed. They also have clutter on the floor. Exactly. There's kind of some items on the floor. I see one of them, they have a cupboard that's halfway open. That's just asking someone to run into it and get a skin tear. Then we have on the other picture, there's oxygen tubing. That's a little bit of a loose rug that's there in the bottom. And I like this picture, and we'll talk about it a little bit later, but being able to go in the home and assess someone's risk factors for falls is worth, is worth gold to be able to do it. Because certainly when patients come into the clinic and we ask about, their risk for falls, they're not necessarily going to mention, well, I have oxygen tubing on the floor and I have, cupboards that are halfway open. But if we're able to go in the home and kind of see things with our own eyes, we can help further reduce risk of falls. But let's talk about screening for falls. We're going to talk about some tools both in the ambulatory setting as well as the inpatient setting. So the American Geriatric Society recommends screening people 65 and older for falls once yearly, and that the number needed to screen to prevent just one fall in 1 year is 20. And what that lets us know is that you really get a lot of value by doing a pretty simple screen. And we're going to talk a little bit about those tools. So the STEADY, I'm not sure if you're familiar with that resource. I have a link at the end of my presentation for these resources, but STEADY is the Stopping Elderly Accidents, Deaths, and Injuries. It is an initiative from the Center for Disease Control, who put out not only patient education materials, but also provider education materials to reduce falls in older adults. But they have a screening tool that places people in a low, medium, or high risk category, and we're going to take a look at that in a minute. There's also a 3-question screening tool that indicates if someone is at high risk for falls. And in the inpatient or rehab setting, the Morse Fall Scale is a screening tool that you can use, and that puts people in either a no, low, or high risk category. So we're going to move on to the study. And the nice thing about the study is that this is actually a screening tool that patients can fill out themselves. It's a 14-item screening tool, and it has questions like, have you fallen in the past year? Do you feel unsteady when you walk? Do you use furniture in the home to kind of move about safely? And that essentially, if you answer yes to any 4 of these items, or the top 2 have a little more scoring credit, then you're determined to be at risk for falls. But the nice one is that this can be done in the office, while someone's waiting for an appointment. It can even be filled out kind of with the assistance of a family member. So that's a nice screening tool. The CDC also talks about the 3-question screening tool. This one is really straightforward, very quick to use. You feel unsteady when you're standing or walking. Do you worry about falling? Have you fallen in the past year? And if they say yes to any of those things, you ask how many times and were you injured? And if this is positive, that indicates someone needs a little more intervention to reduce their risk of falls. And then the Morse Fall Scale, that one again was the one that is used sometimes in the hospital or rehab setting. And you'll kind of see why when you take a look at the questions. But it talks about a history of falls. Some of it is used on kind of nursing assessment or clinician assessment. Do they use a cane to walk? And then asked if they're on heparin, are they able to get out of bed independently? And that you can see in that lower left corner that if they have no risk, then you just kind of do regular kind of hospital safety interventions. But as their risk goes up, you kind of escalate your fall prevention intervention. So let's talk about interventions. So if someone is deemed to be not at risk at all, the CDC still recommends that you educate patients on fall prevention. They also recommend that you assess vitamin D intake, because not only do people with a low vitamin D have an increased risk for falls, but certainly can eventually kind of impact your or can have a risk for fractures. They recommend that if someone is deficient in vitamin D, that you replace it, and we'll talk about normal values a little bit further in the lecture. They recommend that even if you're not at risk, that you're referred to a community exercise or fall prevention program. Because as we talked about earlier, that any fall means that you are at risk, significant risk for future falls. And so this is really kind of getting at that preventative intervention to not even fall in the first place. And then they recommend that you reassess or screen people annually or anytime that they have a fall. Then you do a repeat screening. But let's say that someone is identified as being at risk. So what are we going to do at that point? Well, they recommend that we assess a patient's modifiable risk factors. So the first one is to evaluate gait strength and balance. And we're going to talk about 3 of the assessment tools that you can use to be able to achieve that. So the timed get up and go, I have it in US and metric. The patient is at risk for falls if it takes them more than 15 seconds to complete the task. So essentially what they have you do is you sit on a chair, you stand up, you walk 3 meters, turn around and walk back. And if it takes longer than 15 seconds, then they're deemed to be at risk. The next one is a 30-second chair stand. So this one, they have you sit in the middle of the chair. You place your hands across your chest so you can't use your arms to assist. Keep your feet flat on the floor. And then when the person timing it says go, you rise and then sit back down. And you repeat this for 30 seconds. And you're supposed to count and record each number that the person's able to do. And you can see on the left that there's a normal value for how many people are supposed to be able to do. I will tell you that between the timed get up and go and the 30-second chair stand, I actually find that the timed get up and go is the one that's used most commonly. The other thing I like about the timed get up and go is that it gives you some additional clinical symptoms. So if someone is doing that walk back and forth and they're really short of breath, or they're kind of a little bit wobbly, that in and of itself really provides you some additional details that isn't included in this 30-second chair stand. So that is the one that I would probably use and have used in the outpatient setting. Another one is the 4-stage balance test. So you have the person start out side by side, then they kind of split their stance and eventually do tandem. They're supposed to hold each kind of stance for 10 seconds. And if they are able to complete it, you progress to the next one, ultimately to standing on one foot. Again, I think the timed get up and go is the one that's used most commonly, but it's nice to have as many tools in your toolbox as possible. So now let's switch gears and talk about some interventions. So you've determined that someone's at risk for falls, you've done your assessment, and now you're going to do some interventions to reduce that risk further. So gait and balance training in and of itself can cause a 20% reduction in fall risk. I've called out specifically Tai Chi as a resource. So Tai Chi has actually really been well studied and is specifically called out as an intervention to support strength and balance by the Center for Disease Control. And there actually was a study done here in Portland with local residents that found that Tai Chi ended up reducing risk for falls or falls for about 55%, and that the number needed to treat to reduce an injurious fall was only 9. And the other thing is that it reduces fear of falling. And as we mentioned before, fear of falling in and of itself is an independent risk factor for falls. So it kind of has this multifactorial approach to reduce risk for falls. And then this is a little more research about how helpful Tai Chi is. And this was a meta-analysis of 10 randomized controlled trials that did show between a 43 and a 50% reduction in falls. And that it appears that fall risk reduction is actually even longer term, because they did an assessment at 12 months, and it's still, as they continue to participate, continue to reduce the risk for falls. So a next risk factor, a modifiable risk factor that we can take a look at, is identifying medications that might be increasing risk for falls. So there are lots of medications that can increase risk for falls: antipsychotics, anti-anxiety medications, so any benzodiazepine. For us, it's like lorazepam, clonazepam, Xanax. All of them increase risk for falls. Hypnotics or sleep medications like Zolpidem, and then antidepressants increase risk for falls, as well as many antidepressants can cause orthostatic hypotension, which can be especially dramatic in older adults. Opioids can increase risk for falls. Anti-Parkinson's medications, which is difficult because oftentimes we're using those medications because of the motor abnormalities related to Parkinson's, but they can also increase risk for falls. And then anticholinergics, a common one is oxybutynin, or a bladder medicine, and then Benadryl, and then cardiovascular medications like diuretics and antihypertensives. And then on the side of this slide here, I've included the Beers list. For those of you not familiar, this is a list that's compiled by the American Geriatric Society. It's updated every 2 years, and we're about to get a new one out this year. But it really does an excellent job of identifying medications that are high risk for older adults, not just for falls, but for other adverse events as well. And I have included that link that's there. I've included in the resource slide at the end of this lecture, so you'll have kind of that resource as well. But it's really, really helpful. I use it on a regular basis. I would highly recommend that. That's another tool you have in your toolbox for older adults. The next thing we talked a little bit about is potentially trying to reduce home hazards. And you guys took a look at those pictures, so you already know what kind of home hazards are at play. But again, if someone has stairs, that they mark the edge of their stairs so that the edge of it is a little more apparent, that they make sure that they don't have those electrical cords or oxygen tubing in the middle, that they declutter it. Another thing is that I think doesn't get considered a lot is to make sure that their chairs in the home or the toilet are at appropriate height, because a lot of falls happen when patients are getting on and off the toilet in their bathroom. If someone is what we call a furniture surfer, so if they're using the edge of the furniture to kind of help them get around the home, which is pretty common, we always recommend that you use an assistive device like a cane or a walker instead, but sometimes people will insist on doing this, that their furniture isn't at an appropriate height so it can actually be helpful and that it's not an obstacle to them. Night lights, non-slip pads in the shower or tub, grab bars, that there's handrails along staircases, and that there's even non-glare lighting. And I think this is important and something we don't really consider a lot, because if we think that there's a big light over the staircase, that's probably all they need. But certainly if it has a high glare, it's difficult for an older adult with decreased vision to be able to see things that have that high contrast. And then, like I mentioned, consider a referral to occupational therapy or your therapy disciplines for a home safety evaluation if you're not able to go out in the home yourself. We can always use the aid of our colleagues in reducing risk for falls. Another intervention is to measure orthostatic blood pressure. So this is one we see a lot. As I mentioned before, there are many medications that can cause orthostatic hypotension. And so it is a pretty common issue. Orthostatic hypotension can also just kind of happen as a result of aging. You know, we talked about our system becoming less sensitive. Blood pressure can also affect our baroreceptors, and our baroreceptors are what help us kind of maintain our pressure when we change position. This can be a part of aging as well. So for those who don't know what an orthostatic blood pressure is, that's when you take the blood pressure laying and then standing. If there's a 20-point drop in that top number or a 10-point drop in that bottom number, that's considered positive. And then I always recommend that you also assess for symptoms of dizziness. And keep in mind that for older adults, they may not actually notice that they're kind of dizzy. So we'll hear a lot for these people who don't notice their symptoms. They'll talk about like, well, I don't get dizzy when I get out of the chair, but they'll have a pattern of kind of walking a few feet and then falling once they've gotten up. And for those people, I have a strong suspicion that they have orthostatic hypotension. Again, if there's medications that are causing it, that we come up with a plan to stop or reduce those medications or to find one that's safer. And then there's some what we call non-pharmacologic interventions or non-medication interventions that can be done, like foot pumps before people standing or kind of squeezing their calves, making sure that they're maintaining their hydration, that we educate them about being very careful when they change position, and then compression stockings. But of course, these aren't as popular of an intervention because compression stockings are very hard to get on. So sometimes it's hard to get patients to wear them. Next one is to check visual acuity. Someone had mentioned when we did kind of a popcorn, what's the risk for falls? Someone had mentioned decreased vision. We recommend using a Snellen eye chart or something similar. That Snellen eye chart is that blurry thing in the background. And obviously refer to our ophthalmology or optometry colleagues if there's abnormalities. And to keep in mind that there are medicines that can also affect a patient's vision. And a common one that this includes is anticholinergic. So if you see someone is on this or they're complaining of blurred vision and they're on this, to make a plan to stop or change it to something else. And I want to take a moment to talk a little bit about bifocals versus single focal lenses, because this comes up a lot for older adults with falls. So there actually was a really good randomized controlled trial that was pretty large. And it took a look at people who were multifocal wearers, so like bifocals, trifocals, who'd fallen in the past year or had a timed get up and go that was abnormal, so greater than 15 seconds. And they found that for community ambulators, their falls were prevented by getting rid of their bifocals and progressive lenses. So for people in the community who've had falls, if you get them to instead have a pair of readers that they use and a different pair for distance, it significantly reduced their falls. And they actually only needed to treat of 2. But they did find that in patients who are less active, who are homebound, that single lenses increase the risk for falls. And I don't think we know why this occurred, but I think it's important to call out since we are dealing with kind of both of these populations in older adults. Another one is to assess feet or footwear. So there actually was another really good study done about footwear, and they found that the athletic and canvas shoe was the safest, and that other types of shoes increase falls by about 70%. And they actually found that going barefoot increased your fall risk by about 1,000%, which is pretty significant. And then if you're going to educate people about shoes, you make sure that you talk to them about heel height, as well as choosing ones that are non-skid. The other one, like I mentioned before, is to assess vitamin D intake. So for anyone with a vitamin D level of less than 30, we recommend starting 2,000 units of vitamin D per day. And that for people with a vitamin D of greater than 30, they can get away with a little bit less, but they actually recommend that you do put a vitamin D supplement on them. And so calcium plus D is often one that can be used in the. And then we identify comorbidities. And as mentioned, there are a lot of medical conditions that contribute to risk for falls. I think some of them you probably already knew, that arthritis, if you have pain, if you've had weight gain, if there's cognitive impairment. But I think some ones that I wouldn't necessarily think of, but depression and anxiety increases your risk for falls. A little bit of a catch-22 because we also talked about antidepressants increasing your risk for falls. And then medication or medical conditions like heart failure, COPD, diabetes. I think another one that is not often thought about is a vitamin B12 deficiency. So a lot of patients can have an unrecognized B12 deficiency. And if it gets significant enough, it can cause falls. And untreated hypothyroidism is another common one that I don't think gets considered very often. So this is a little bit of a visual of the study, the CDC guidelines that I mentioned. This is a little bit of an example of kind of the provider-facing information that they have. It's like very easy to use. It's very easy to navigate their website. And they also have patient-facing information that's easy to navigate. So I've included that on my list of resources as well. We're going to take a little bit of time to talk about some upcoming research and technology. And I added this kind of towards the end of my talk because I thought it was just really interesting information. And I thought you might find it interesting too. So an article that was published in American Journal of Physical Medicine and Rehabilitation found that the research that is currently out there generally spans about 4 domains, and it's fall risk assessment, fall detection systems, fall injury prevention, and fall intervention. And we're going to talk about the findings of this analysis of the research. So they found that some of the technology being used for fall risk assessment in the outpatient or home setting is using an instrument gait mat or accelerometer technology. And an example of the gait mat is up in the top. You can see the WeFit gait mat, gait is an example, and then they have kind of another example. And then accelerometers are the ones that are there at the bottom. That's kind of like wearable technology that might be used to assess risk for falls. Most of these instruments can either be worn or, like I said, be a sensor mat. The benefit of these interventions is that they can predict gait variability, which has actually been shown to be a predictor of falls, but that some of the barriers to this, to these interventions being used, is that it usually requires assistance to either be put on the patient or to be kind of set the patient up for the intervention. And so that was a limitation in their value as a risk assessment. Another one in the hospital setting is they're actually using the electronic medical record and the data that's in there to see if they can predict risk of falls for someone. And they're also using that data as what's called prescriptive analytics. So not only are they using it to predict the risk, but then to make patient-specific recommendations around it. And while the researchers who talked about this literature felt that it was promising, that there really isn't a lot of literature that has been peer-reviewed on the efficacy of these interventions. But I thought it was an interesting thing to kind of think about, and probably an area that we'll start to see a lot more research in as we go along. Some interventions that are being done in the home setting to detect falls. These usually fall in the category of sensors that can be worn, or even pressure sensors. And some of these can be paired with smartphone technology to provide real-time alerts. So if someone has a fall in the home that's detected by the sensor, it can send something to the police department or fire department or a family member. The wearable sensors are usually pretty low in cost, but that a lot of the patients talked about the size of the sensor being uncomfortable, and that limited the patient's willingness to wear it. And then there are ambient sensors, so kind of a camera set up in the home. These are less of a hindrance to patients, but can be limited due to privacy issues. And then obviously it doesn't go along with the patient wherever they go. So if they have a fall outside of the home, it would make this irrelevant. And then they also had a lot of false alerts related to pets or other people in the home. And fall detection systems in the hospital, mostly this fell under the category of video monitoring. Video monitoring has been successful at reducing risk of falls, both in the hospital and rehab setting. And they're thinking that it might be helpful to also identify patient characteristics that may have triggered a fall, but that they're pretty costly and that can be a barrier. And then I also kind of put out there that patient privacy can be a barrier to using these as well. And then bed alarms are often used. These are either for pressure or infrared, and they're used widely in rehab and hospital. And that they found that ones that are a combination of pressure and infrared seem to have better sensitivity, but that hospital and rehab employees already had alarm fatigue. And so that was a little bit of a barrier to their being used. And then I don't know if you use bed alarms where you are, but these can be really alarming to patients. And so if we have a patient with dementia that's at risk for falls, or even someone that's recovering from delirium and they're easily kind of agitated or overwhelmed, having this like huge alarm system can be really overwhelming for those people. Another interesting area of technology is fall injury prevention. So the ones that fell in this category are wearable airbags. So they have some that are belts, vests, or jacket. And how they work is they contain multiple sensors. And when someone falls, it triggers an airbag deployment. There are a couple of pictures of them there. There isn't a lot of research about how effective these are for preventing injuries. And then another big barrier is that there is a significant cost for these items. Another area that they found in their research was using exergames or virtual reality technology to help reduce risk of falls. So they found that actually virtual reality games showed an improved reduction in falls, as well as an improvement in balance. And they found that the exergames, an example of that is like an exercise game like the Wii program. They found that their protocols varied pretty widely in the research, and that some showed a positive effect, but that there wasn't a lot of consistency among the data. And then again, some of the barriers to this could be cost, or with difficulty with setting these interventions up. And then the last one that I found most fascinating was that there is some fall intervention robot technology that's currently being researched. One of the ones they came across was a personal coaching robot. And this robot was in a senior housing center, and it had a display screen that gave educational materials and reminders about exercise and fall prevention. The results showed no incidental falls in the intervention group, but it was a single study, so it's difficult to interpret. So I don't know if we'll see more research on that as time goes on, but I thought it was interesting. And then another one that they found was a walking aid cane robot. So this is a walking cane that's also technology, and it would analyze the participant's walking pattern and would change to a fall prevention mode if an abnormal gait is detected. And this one, we don't have results yet because research is ongoing and still pending, but I thought it was an interesting thing for us to keep our eyes on the horizon for fall prevention. So this is that resource page that I talked about. I will make sure to send a copy of my slides along after this presentation so that the information is available for you there. The study, the Center for Disease Control, I mentioned, talked about patient facing materials as well as recommendations for the ambulatory setting. The Agency for Healthcare Research and Quality has good resources for fall prevention in hospital as well as long-term care settings. And then that Beers list with the American Geriatric Society, the link for that as well. And then that's a picture of where I grew up. That's a bridge in Newport, Oregon. I want to thank you for allowing me to present today. And that is my contact information. You're welcome to reach out to me if you have questions. If you lose the resource slide and are hoping to get, an update on any of the resources, I'm very reachable by email. So please don't hesitate to reach out to me. I'm going to take myself out of screen share mode so that I can see everybody. And I'll start looking in the chat for questions, but everyone is certainly available to unmute themselves and also ask questions. Perfect. Yes, does anyone have any questions for me? Or maybe I'll start asking you. Oh, yeah.
Yeah, I'm Tan from BHQ. I'd like to ask you about the sensor of the inpatient, the setting in the hospital setting, for the bed alarm with the sensor, infrared sensor, and pressure sensor. Do you have any experience about the infrared sensor or not?
I don't. Our hospital really only uses the pressure sensor system. And actually, when I think back, all of the hospitals that I've worked at have only used the pressure sensor system. Do you guys have something similar where you work?
Yeah, right. We have the pressure sensor, but it can, it's like have a problem. It's not like real time.
No. Well, and they kind of talked about in the research too, they called out that, if you don't have kind of the staff or the systems in place to respond quickly when that happens, the tool is only as valuable as your ability to respond. And that's certainly a limitation that we have, that you can hear it from kind of the other end of the hall. But if if staff is in another room and not able to intervene, it only has so much value. Yeah. Good question.
This is a problem too.
Yeah, exactly.
Okay, thank you.
Jessica.
Yes.
Hello.
Hello.
I'm Dr. Mani and my team in the Smithiway Sukhumvit Hospital, Bangkok. Can you explain more about the Excel game and the virtual?
Yeah. So the virtual one, they didn't talk about a brand name in the research. But the Exergame, the one that is studied the most is like We Fit technology. And I've actually seen those in the skilled nursing facility or rehabilitation setting where they're using some of those games. There are actually fall prevention games and gait games that they're using specifically for rehab. So those are the ones that are most studied. Does that answer your question?
Yes, thank you.
Yeah.
How about virtual?
They didn't call out any specific brand of that one. So I'll tell you what, I will do a little more research on that and then get it back to the group about what kind of virtual reality games they're using specifically for fall prevention.
Thank you.
Yeah. Let's see. Ooh, interesting. There's some good questions in the chat. Any to activate? Any internet or social media link up home hospital system you know or recommended to activate for fall at home? Are you asking kind of in that system where they wear a wearable sensor, is it linked to a hospital system? Is that what the question is? Yes. So how it's done here, I'm trying to think. My dad actually has a system. I can't remember the name brand, but how it's, you kind of have a variety of options. The typical one is that it's a wearable sensor, and if the person can push it if they fall, so they can push a button if they fall, or the ones that have that sensor technology, like in a watch or a necklace, they usually also have kind of a two-way technology. So it's a call system in the background, like a centralized call system, and they'll speak through the person's watch or their necklace and say, "It looks like you've fallen. Would you like us to call an ambulance?" And so there isn't a direct link to a hospital. I think the home sensor ones the ones that are kind of like video and not a wearable monitor, they have similar technology where there's a two-way communication where they say, "We've sensed a fall. Would you like us to send someone out?" And then they would have emergency response show up. I've heard this same thing about Apple Watch. So Apple Watch, and I don't know what year of Apple Watch, so probably maybe not all the Apple Watches, but they have a sensor in it for an abrupt change in position. And so a lot of them have that. I think when I was, when you kind of do the research on which one is the best, there's pluses and minuses to all of them. The Apple Watch, that's not what it was specifically designed for. So I think the ones that are kind of more simple and that's their only purpose seem to work more reliably. But if someone is already an Apple Watch wearer, I would definitely recommend they use that technology. Let's see. There was an earlier question, what tool do you recommend to assess fall risk in a public area? Ooh, or like a mass assessment for healthy older adults. So you're talking about maybe there's like a health fair set up and you're at a place and you want to be able to assess the risk for falls. And they're outside maybe, not in a clinic. I think if that's the question, I would recommend still the timed get up and go. You can measure the space kind of ahead of time. You can still also use your regular fall risk assessment screen. If you're trying to have kind of a larger intervention, say you're at a community event and you want to improve education about fall risk reduction, that might be an opportunity to just start with a basic set of questions and just that basic timed get up and go, and then have additional resources for those people who are identified at risk. Did that answer the question? Hopefully. If not, just unmute yourself and correct me. Okay, perfect. And then How can we assess patients' concern about falling? So that's one of the CDC's kind of fall risk screening tools. And then it's also part of the 3-question screening tool, the one that's really quick. Have you fallen in the last year? Do you feel unsteady? Are you worried about your risk of falls? And that one is just so quick and gets you a lot of good information. Certainly the big long one that they fill out where they have about 14 or 15 questions that they can fill out on their own gives you a lot more kind of information about their overall picture. But if you're looking for something fast that will help you identify if someone is at risk for falls, I think that 3-question one is really helpful. Perfect. Those are all the questions in the chat. Are there any other questions? You can unmute yourself. Do you guys feel that you're going to be able to take some of these interventions and start to use them in the settings that you're working in?
Hello, Jessica again.
Yeah.
Do you have the experience about the Tai Chi exercise to your patient?
Oh, did you say tell you about my experience with Tai Chi?
Yeah, right. Is can help patient one by one or the group exercise with the Tai Chi?
Yeah, thank you. That's a great question. So we actually, most of them are set up in a group. That's how most of those interventions, like when they did the research, it was generally done in a group setting. But we have been, especially in our department, big proponents of Tai Chi as fall prevention. In fact, one of the person in charge of geriatrics in our clinic does a lot of research on this topic. But we had to kind of change when COVID hit. People weren't able to do those group activities anymore. But we actually found that people still had good experiences when they did an online video and followed along with a video on Tai Chi. So even though they weren't able to have an on-screen instructor, an in-person instructor, and weren't able to do it in a group setting, they still had a reduced risk of falls by doing the online version or YouTube video versions.
Okay, thank you.
Yeah. I think if it would be helpful, I'm going to share my resource slide. I'll share that in the screen so that while people are kind of logging off and starting to move on with their day, because I know you have a busy day of work, that you have that to take a picture if you would like. And then keep in mind that I will be sending these slides along after this presentation so that you'll have them for your records as well. Are there any additional questions? If there are no other questions, then I'm going to sign off, but I want to thank you so much for allowing me to come here today to present this information and for you to take time out of your busy day to allow me to talk about this very important topic. So thank you so much for having me. And I'll email those resources to you about the virtual reality. So you'll have that as well. And feel free to reach out if you have any questions. Thank you so much.
Thank you.
Thank you. Thank you very much.
Have a nice
Jessica.
night.
Thank you. Take care.
Thank you,
Thank you.
Jessica.
Thank you.
Thank you. Goodbye.